Okay. Welcome, everyone. Anat, take it away.
All right. Good evening, everyone. I'm Anat Geba, Director of Strategic Initiatives for No Shame on You. And on behalf of the Board of Directors, of staff, and volunteers, I warmly welcome you to tonight's program. A little bit about No Shame on You. We are dedicated to eliminating the stigma associated with mental health conditions so that people who need help will seek it, family members and friends will know how to provide proper support, and ultimately to save lives. And we fulfill our mission through comprehensive community outreach programs, workshops, teen programs, free resources, and a robust online presence with over 120,000 social media followers. And we partner with organizations throughout Chicagoland and across the country. And we're recognized for our inclusive, consistent, and responsive programming for people of all ages and backgrounds. I want to express our gratitude tonight to the community partners that were displayed in the pre-roll slideshow. And before I introduce our speaker, just a little bit of housekeeping. We're going to hold a Q&A session at the end of the program. Most efficient, best way to do it is if you have questions, submit them directly through the chat to Wendy Singer at our executive director. So that's Wendy Singer at No Shame on You. And then we will address as many questions as time permits. It's now my pleasure to introduce this evening's speaker, Joe Feldman, founder and president of Cover My Mental Health. Joe became an advocate for mental health care access after successfully challenging a family member's insurance treatment denials, including through a federal lawsuit. His advocacy work has included policy-driven discussions with legislators and regulators, a board role with the Kennedy Forum, Illinois, presentations to parent groups, and publications of actionable guidance, such as a 2021 article in the Journal of Psychiatric Practice on medical necessity letters, which I'm guessing we'll learn about a little bit tonight. So thank you everyone for joining us. Thank you, Joe, and take it away, Joe.
There we go. Are the slides up?
You got it.
Great. Well, thanks, Anat, for your kind introduction, and Wendy for stimulating this event tonight. It was a great conversation not too long ago that led to this opportunity. I started Cover My Mental Health after being involved in advocacy for about 6 or 7 years. And as Anat mentioned, I got involved in this when one of our kids needed care, and we were able to organize that. But our insurance company decided after not too long that the care was not medically necessary. And so they were wrong. And we had I'll say the luck to be able to dip into our savings and maintain the care and deal with the insurance company later. We appealed the denial. That appeal was not successful, but we did win a federal lawsuit against our insurance company that demonstrated in, I'll say, very black and white terms that their decision making was wrong. And that's really what motivated me to get involved in advocacy, because families shouldn't have to go to that much trouble. Certainly, lawsuits are a terrible strategy when it comes to accessing insurance coverage that you paid for. And it turns out that there are a lot of steps that can be taken far before a lawsuit, which is definitely ill-advised. They're just very, very difficult to pursue, and even before appeals. And we'll talk a little bit about those. So first, I'd like to talk a little bit about the kind of expectations that we have, if we even stop to think about it, when it comes to our health insurance. And I'd say for the most part, things go as we would expect. We expect that certainly with physical health or even with surgery, that we'll be able to identify an appropriate clinician. We'll talk about what that means specifically. And we expect that the insurance coverage is going to be quite clear. We'll talk about that too. And that as treatment progresses and it evolves to higher levels of care, lower levels of care, different levels of care, that treatment will continue to be covered. And then that the claims are going to be paid. And we understand there'll be deductibles, so there might be co-pays. And that if there are disputes along the way, that those disputes will be resolved with the patient, with our family member, and their interests in mind. So that's what we expect. And it turns out, I'll say, especially when it comes to the mental health and substance use disorder care, that these expectations are not met too often, and that's really what Cover My Mental Health is all about. So I launched Cover My Mental Health at the beginning of last year after a conversation with Dr. Claudia Welke at the Compass Health Center up in Northbrook. That's an organization that some or maybe many of you know. Claudia and I had a conversation about an insurance company who was threatening to deny telehealth coverage to anyone, and Claudia was very concerned that meant that folks who had really come to depend on telehealth in the mix of how they accessed their care were going to be in trouble. And she and I had a conversation about that, and that ultimately led to our thinking about how do we help patients, or especially patients' families, with resources that they can use immediately to push back on insurers. And that's really what Cover My Mental Health is all about. So before I talk about the specific expectations on the earlier slide and how they might be disappointed and what we can do to support that, I want to just talk a little bit about how we try to organize the resources on our website. So first and foremost, I think that we want to provide encouragement. Encouragement that you don't have to take no for an answer, and that you, meaning you as a patient or you as a family member, are your own best advocate for access to care. I really believe that if you don't have a level of encouragement that you don't have to take no for an answer, that the best resources in the world are just not going to do you any good, because you'll be disinclined to take the time to use them. So we try to make the resources that are on our website as easy to follow as possible, and we describe different steps for getting started, and we provide some tips for success. I'll share a few of those. Then we really try to go directly at the obstacles that are typically encountered and how to engage the insurer directly against the obstacle that they've raised, and to deal with that on a very, I'll say, on a very factual basis. I remember in a presentation just a few months ago to a group of clinicians, one of them said, you just have to be really aggressive with the insurance company if you want to be successful. And I said, so that might be true, but I don't really know how to teach or how to coach somebody on be really aggressive. And so what I would like to think is, if our resources and the encouragement that we provide are straightforward, then we don't have to worry about being aggressive. We can just use the evidence that we have to push back on insurers. That's the goal. And then at the far right side are some additional resources that may be available if the initial steps don't get you to where you need to be. So I'll say sort of, if at first you don't succeed, what that might look like. So when it comes to tips for success, I want to share a couple that are on our website. This is, I think, the last screenshot from the website that I'll include. I just want to touch on the first two. So when it comes to talking to insurance customer service reps, you're going to help yourself most if you take notes of who you talk to, the date, what the substance of the conversation was. Doesn't have to be at the level of a transcript, but just to document the conversation for future reference. And And we have a really, I think, helpful video on the site in this section about what to do when customer service reps ask questions about clinical matters. So I'll say the spoiler alert is don't do it. It's not a clinical conversation with a customer service rep. And the video that we have online is, I think, a fun way to sort of reinforce that. The second tip turns out to be incredibly well received when I talk to clinicians. And the tip is this: every single health insurance policy has on the website, or for the asking, a form that you can use to delegate or to give responsibility to a friend or family member to help you with dealing with insurance. So when you've got a family member who's got troubles, with mental health or substance use disorder, it could be that even with the best possible encouragement and the most straightforward resources, it's still just a little bit too much. And it could be that the move that you want to make or to consider is to reach out to a friend or family member who might have offered to help. I certainly know when our family's gone through different challenges, we'll have friends or family say, can we go to the grocery for you? Can we bring a meal? Can we run a carpool? And it could be that there's someone in your orbit who has I'll say, the demeanor and has the trustworthiness, the relationship of trust that you could say, what I really could use is a little bit of help dealing with this insurance company. And that might be one way to, I'll say, spread the work and to get a little bit of help along the way when you're dealing with a challenging situation. Let's talk a little bit about the first expectation of being able to identify an appropriate clinician. So insurance companies provide a network directory, typically online now, where you can look up clinicians and use that list to find an appointment. And when I say I'll say an appropriate clinician, I think of three different dimensions. One is clinician that has the right clinical expertise. So if you're dealing with anxiety and depression, you want someone who can help you there. If there's an eating disorder, someone who has that expertise. So that's, I'll say, the first dimension. The second is that the clinician is close to you, and close is defined different ways for different insurance plans. Some states define close in terms of how many minutes to drive or how many miles to drive. I don't really worry about that so much, just to say you'll know what close is. And it could be that if you're, I'll say, in a rural area, close could be 20 miles away because it's only 20 minutes. And if you're in an urban environment, it could be that 20 miles away is just too far. So you'll know what that looks like. And that you should be able to get an appointment soon. So if it's an emergency, soon means probably today. If it's not an emergency, soon means probably in the next week or two. But we know that soon does not mean in 6 months or 3 Thursdays from now in 2027. That's not soon enough. So what to do if you are running into an issue with a network? So on our website, you can download this worksheet, and this is a way of showing your homework. So using the network directory to document that you've made some phone calls or reached out by email, whatever method is provided in through the network. Maybe it's an online request, to be able to document that you have done your job, you've done your part, which is to say, I've tried to schedule an appointment with a clinician who has the right clinical expertise, according to the directory, and is near me and looking for an appointment soon. So if you've tried and you've succeeded, then you're all set. And if not, this worksheet can be used to show your work and to talk to the insurance company to get what is probably called a waiver, so that you are either given, I'll say, authorization to use an out-of-network provider, out-of-network clinician at an in-network rate, or to impose upon the insurance company that they will find an appointment for you. So the key is your expectation that you should be able to find a clinician with the right expertise soon and nearby, completely reasonable. And it's also reasonable that you have to do the work to try to find an appointment. And having done that work, that the insurance company then needs to be responsible for their job, which is to be sure that you can get an appointment. By the way, you might hear the expression ghost networks, and there's been a fair amount written about ghost networks, and so this turns out to be a challenge more often than you might expect, and certainly more often when it comes to mental health and substance use disorder care. So for the middle expectations around understanding insurance coverage, what we expect is not to be surprised. That's really as simple as it is. We expect that a clinician who is competent and is in the network directory is going to be able to figure out what the right care is that we're going to need, and having figured that out, to be able to be confident that it's going to be covered. And as the relationship between the clinician and the individual proceeds, that the clinician is the one who's going to have the most up-to-date information to be able to monitor progress or perhaps regression, and be able to make timely decisions about what that care should be. So to say it out loud, it almost sounds silly, right? So a clinician decides the kind of care you need. That's what they're trained to do, and the insurance company somehow doesn't agree. So why does that even happen in the first place? So last summer, I was having dinner with a close collaborator, Dr. Andrew Gerber. He's a psychiatrist who runs Silver Hill Hospital in Connecticut, which is one of the leading psychiatric facilities in the country. And he said it to me so clearly, and I've tried to articulate his description on this slide. So clinicians are trained to do no harm. That's the Hippocratic Oath. It's about 2,500 years old. And I'm guessing that you've all heard about the Hippocratic Oath. And we also know that clinicians are taught, they're trained to use safe and effective care. That's another phrase that's in the common vernacular. And most importantly, they're taught what are the generally accepted standards for this particular area of clinical care that they're involved in. So generally accepted standards are what clinicians apply to determine what care is required. So what about insurers? So if you look in your health insurance policy, you will almost assuredly find a phrase that says, we will pay for and we will cover care that is medically necessary. So what Dr. Andrew Gerber said to me is, when we go to medical school or we go to other programs for our clinical training, we are never taught about medical necessity. It's a legal term. It's not a clinical term. And so as soon as you have clinicians on the one side saying, we're going to practice with generally accepted standards, and you have insurers on the other side saying, we're going to evaluate whether something is medically necessary. If there's any gap between those two, then you've got two different rule books that leave open the possibility that there's going to be a disagreement or some different interpretation about what the right care is. So that's what we aim to eliminate with resources that I'll share with you now. So this notion of medical necessity is important for clinicians to be aware of. And when I have the opportunity to present to clinicians, I spend most of the time talking about a medical necessity letter. So this journal article, which was mentioned in the introduction, was from July of 2021. And I was fortunate enough to have as my co-authors Mark Dubofsky, who's a litigator in this area, Eric Plaken, who is the recently retired head of the Austin Riggs Center, which is another of the leading psychiatric programs in the country. And Cheryl Potts has been involved in mental health care access. And the goal of this article was to teach clinicians about medical necessity letters and how valuable they can be in dealing with insurance companies who are not on the same page. I'm also really excited to share that just this week, there was an article published in Psychiatric News about medical necessity letters and about Cover My Mental Health that reinforced the ideas that were in this journal article from 4 years ago, long before Cover My Mental Health launched. And that article is available online now. So what is it about these medical necessity letters that makes them so valuable? So the way I like to think about medical necessity letters is this. It's like a conversation between a clinician and an insurance company, but it's in writing, and therefore it memorializes their thinking. So the conversation that you could imagine would be, so I'm Joe Feldman, and I'm practicing. I'm trained in a certain area. I trained at a certain university, a medical school, or some other program, and my practice consists of the following specialty areas. So I'm qualified to be making these decisions, and then a description of the summary of the clinical assessment and a description of the relationship that I have with the patient. I'll describe the specific generally accepted standards that I've applied in this particular patient situation and how those standards were relevant, and then conclude with the medically necessary course of treatment. So you can I hope imagine this kind of conversation between a clinician and an insurance company, but it's in writing. And on our website is a downloadable template that makes it, I'll say, as easy as possible for a clinician who's never written one of these before to be able to quickly access a format and prompts that help them to provide this letter to their patient and to the insurance company. So again, the whole point is to close the gap between the generally accepted standards that the clinician is practicing and the legal standard of medical necessity, so that you've got the two on the same page as much as possible. So let's talk about the last of the four expectations that I'd introduced early on. So we expect that claims are going to be paid, right? And so there might be deductibles or copays, but we mostly expect not to be surprised. So in a health insurance policy, there is, I'll say, almost every single policy I've ever seen, there's language that says, if you have a disagreement with us and you want to try to resolve it, you should file an appeal. And that appeal process is spelled out in a very detailed way, and that's the course of action that is available to you. That's not true. And the goal of Cover My Mental Health is to help individuals with resources that they can use and processes that they can take advantage of before a formal appeal. So first of all, why is that important? Because an appeal is a legal process. And when the appeals process is described in your health insurance policy, it doesn't necessarily tell you how significant it is that the documentation be extremely detailed, and this is fundamentally a legal matter. It's not a casual matter. And amazingly, there are websites that provide input about how to write a better appeal. And some of them say, what you want to do is write an extremely short and sweet appeals letter. And that just couldn't be more wrong, because as a legal matter, you want to have all the evidence that's available provided in that document. And so I hope I'm leading you to think, why would I want to start there if I could do something different? So we've already talked about two of the different steps that are available before an appeal. One is the worksheet to document that you have not been able to find a provider who's in the network. By the way, the dispute process is typically for denied care. So if you can't even get care in the first place, it's not necessarily obvious that the appeal process that they've offered you is going to do you any good at all, right? So it's already not a fit for all disputes or all disappointments that you might have with your insurance company. And when it comes to denials for not medically necessary, having a medical necessity letter on file first is a really excellent way to go in pushing back on an insurance company who is denying your care as not medically necessary. I want to share a few more ideas of steps that you can take before an appeal that might be successful. They certainly, I like to think, even the playing field. And while I wish I could guarantee you that these are all going to work, it's, of course, a little bit more complicated than that. But the reality is that a more informed, more encouraged patient or a family member is going to be more successful with insurance companies. So one of the other steps that is worth taking is what's called a request, a claims clarification request, where it's basically saying, I want to get a copy from you, the insurance company, of my complete file. I want everything. And this is your right under the law. So we don't spend a lot of time talking about the legal basis for this, but I'll mention this, this right that everyone has to get a copy of the complete file is part of HIPAA. So we think of HIPAA as a law that says confidential patient information can't be disclosed without it being a violation of law. So it turns out that in that same law is language that says you can always go to your insurance company and say, please send me the entire file. Our website has a downloadable letter that you see an image of that at the left. So all means all, but we do include a list. You can see the bullets there of the kind of information that should be included in all. I've used this approach on multiple occasions for issues that our family has had. And it turns out that probably the vast majority of the information that comes back is not terribly useful. It's a copy of the insurance policy and a copy of every explanation of benefits that I've already received. But the part that turns out to be really valuable, or at least it has been in my experience, are call logs and other internal notes of the insurance company that explain their process for having made a determination of not medically necessary. And either the information that's included there that might be helpful, or if they don't have any documentation at all, that's also helpful, because if there's no evidence that says they've done their homework, that's going to be helpful to you as you're pushing back and trying to have them cover you as they should. This is another step that I think is really helpful, and I learned about it from a close advisor as I was putting the website together, and I wish I knew about it earlier. It's called a formal insurer complaint. So let me first say what it is not. It is not an appeal, and it's also not a regulatory complaint. It's an insurer complaint. So the complaint goes like this. You say to the customer service rep, I want to file a formal complaint. And it's for a quality of care failure, just like the words on the page here. And then you explain the quality of care failure. So that could be, there's no one in my network who's available with the right competence nearby and soon, and I need an appointment that you're going to cover. Or it could be that we have provided a medical necessity letter explaining why the care for ourselves or for our family member is appropriate, and we're still not getting your agreement that that's the case. And we have, you're getting the gist of it, I hope, that there's a downloadable form that prompts you to document in writing a conversation that you might have with a customer service rep. So why is this even a thing? Well, it turns out that insurance companies receiving complaints trigger two different reporting obligations on them. One is to their regulatory authority, and the other is to their accreditation body. So all insurers are regulated by either state or federal insurance regulators, and they also have to have accreditation to be in business. And as much as those reporting obligations probably aren't triggered until the end of the year, they must immediately start to keep track of a complaint from the moment you say the words, "I want to file a formal complaint." So you're flagging this particular issue with your insurance company in a way that creates a different process within the insurance company. And after this advisor of mine told me about this, I was quite curious if this was just his experience or if this was something that had broader appeal. And I talked to state regulators and federal regulators about this, and to a number of other ex-insurance company executives, and they all told me the same thing. Insurance companies hate to get complaints because they look bad, right? They have to document what was the complaint and what was the disposition of the complaint. And so by putting a complaint in their lap in a very specific way, you're obligating them to keep track of it and then report back to their regulators and to their accreditation bodies how they handled it. So it's quite possible that the steps we've talked about so far don't quite get the job done. And I just want to highlight some ways that government can help. And you can certainly pursue complaints through state insurance regulators or through the federal regulator, which is called the Employee Benefit Security Administration. Those are possible. They might help. They don't go quickly. That's the reality. But one of the steps that might go quickly, and that I really like to point out, is to call constituent services at the office of one of your elected officials. So this could be someone elected in the state house, the state senate, or in Washington in the House of Representatives or in the Senate. So almost all elected officials in one of those positions has what's called the Constituent Services Office, and their job is to field calls from their constituents on any number of topics or issues related to matters regulated by the government. So I was making a presentation to NAMI's affiliate in Texas. They had an annual conference they invited me to speak at last fall. I was discussing this slide, and this woman stood up and said, "This is exactly right. This is my job." She said, "I work in the Texas legislature, and I like nothing more than when a constituent calls and says, 'I've been dealing with my health insurance company and I need your help.'" And she told the story about how she handles these complaints and how she goes to bat for her constituents by calling the insurance companies. And of course, she stole the show because no one tells it better than someone who wakes up every day and does this. And when she got done, I asked if I could take a short video of her, which I did, and that's posted on her website in this section. And she is just so earnest in describing how she helps her constituents. And I think this is a potential step that you might want to have in your back pocket. So in terms of other steps in the category of if at first you don't succeed, so we talked about a formal insurer complaint and requesting a copy of the complete claim file and constituent services. There's also regulatory complaints. Certainly formal appeals are maybe the step that ultimately is necessary. The documentation of a medical necessity letter, of a formal complaint that's been filed and that has not been successful, and perhaps even a call to constituent services. Those are all bits of evidence that might be helpful in filing a formal appeal, not just because they have been tried, but it shows a level of diligence on the part of the individual that you're taking this seriously and you're trying to get the insurance company to do what they need to do in the first place. So I think your formal appeal is going to be more robust if you've taken these preliminary steps. Our website has information about what should be in a formal appeal to try to help out. We don't have a template appeal because, as I said, this is really a legal step, and we don't provide legal advice. What we do provide, though, is some coaching about the kind of information that you would want to have in a formal appeal. And we also identify different resources that might be available to help you in developing a robust formal appeal. There are certainly resources who are available to do this, who do this for a fee, and there are some resources available online who might be helpful as well. Okay. So I just want to mention one other possible step that might be helpful, and that's what's called a single case agreement. So this is a term that insurance companies use to describe what's basically an agreed exception. So the idea is if and this is it turns out this can be pretty common for eating disorders, but it's also used in other cases where there's a disagreement with the insurance company and they're not prepared to agree that they got it wrong, but they are prepared to agree that they're going to cover it. And so they might document that agreement in what's called a single case agreement. And so this is, you could say, like a side letter that defines their legal obligations and defines very specifically what they're going to cover and what they're not going to cover. So this is something that your clinician might be helpful with. It could be that they have experience with single case agreements. If you work for a large employer, they might also be helpful in agreeing that the care that you're talking about should be dealt with on an exception basis if it hasn't been agreed already, and that they don't need to know the details of your medical information, but they can say to the insurance company, our employee is entitled to this and we're going to ask you to document it in a single case agreement. The one thing I can say is this is something that you'll have to ask for. So that's not something that's going to happen because the insurance company brings it to your attention. You'll have to ask for it. Okay, so just to wrap up before we go into to questions, so your expectations about health insurance are completely reasonable. You should be able to find a clinician in network. That's what you paid for. That clinician should be making decisions about what's covered, and the claim should be paid, and the dispute mechanism should be straightforward and supportive of the patient. I hope that you've got a taste of the sort of resources that are available on our website and how we try to provide encouragement and actionable resources. And medical necessity letters are, I think, one of the most significant resources for a clinician to document their competence and authority to make decisions. There are a lot of resources who may be available to advocate alongside you, so friends and family, potentially government, especially elected officials, possibly your employer, and that there might be steps that are available if at first you don't succeed. Here's my contact information and the URL for our website. And I look forward to any questions that you may have, and or any follow-ups that you might have after tonight.
Thank you so much, Joe. We did get a few questions. I appreciate you being here for us, and your passion is evident, and I'm grateful. A couple of the questions were, sometimes when you are in crisis, you don't have a lot of time. I'm curious as to how long this process has took for you and maybe some of the other clients you've served.
Right. So first of all, that's absolutely true that when time is of the essence, it can be really really challenging. I think medical necessity letters and the clinician's voice in reaching out to insurance companies can be quite helpful. I think as a general matter, clinicians really want to help. And when their patients are at risk and the timeliness of a decision about coverage is whether it's life or death or otherwise significant, the clinician may be the best voice to speak on your behalf. And they can do that certainly in a phone call to the insurance company and back it up with a medical necessity letter.
Thank you. And the next question here in the chat was, what about behavioral health hospitals or PHP, partial hospitalization programs? Can they work with you to get a medical necessity letter as well? Or is it just private clinicians?
No, so a medical necessity letter can be provided by any clinician who is taking care of someone when either there's a denial that's already been received or based on their experience, a denial is lurking. And I encourage clinicians to provide medical necessity letters in cases where you need a prior authorization. So prior authorizations are, I'll say, not as reliable as they should be. So I encourage clinicians to provide a medical necessity letter concurrent with a prior authorization received, because if the prior authorization is rescinded later, it's valuable to have a medical necessity letter on file. When there are changes in the level of care, that's another clinical moment when a medical necessity letter can be helpful. So that could be when a patient is transitioning from outpatient to intensive outpatient, IOP, or partial hospitalization, PHP, or to residential care, or even to inpatient. Those are all occasions when a medical necessity letter can document that there's a different level of care required. So there's no requirement at all that that medical necessities are written by any one kind of clinician. It can be any clinician who is at that moment in the best position to say stand up for the patient.
Is it ever possible that in the realm of behavioral health hospitals or clinics where they just say, we don't work with that insurance, and it comes from that end? And do you have any suggestions if that is something that happens?
Right. So I'll certainly say this gets a little tricky, right? So in a way, it could be a combination of no provider in network and a question about medical necessity. So let me try to, I'll say, deal with those as two separate but very related matters. So if a higher level of care is what's required, the insurance company should still be obliged in their network to provide a clinician with the right competence nearby and soon. And that could be for outpatient care, or that could be for a higher level of care. And if that doesn't exist, then you've got that same worksheet to be able to document, I've identified, or through a clinician, I've identified the kind of care that I need, and I've looked in the directory and I can't find anyone. And so I'm now turning to you to say, it's up to you to provide me with a clinician or to provide me a waiver to be able to use an out-of-network provider. So that's, I'll say, is there a provider on offer by the insurance company? And the question of, is the care that's required really medically necessary or not? And that's really, I'll say, a question that can be addressed, or that should be addressable with a medical necessity letter. So it could be that you've got, I'll say, a combination of those two, where the clinician has said, for example, this particular patient needs intensive outpatient care for, let's say, an eating disorder. That's what's required, and it gives the patient or their family a chance to say, well, I'm going to look in the network directory and see if I can find someone. It could be that the expert to whom the referral's been made can tell you there isn't anyone, and here's the particular expertise that's required and that you should be asking for to see if there's another provider. Now, if it's 100% the family's decision that they want to go to Dr. X, that's their own decision, and the insurance company would, I'll say, reasonably say, you're not taking advantage of the network that we're offering, and so we're going to only cover that on an out-of-patient or an out-of-network basis.
Got it. It really makes me think, like, I wish, I've been through things in my family too, and we had some troubles, but we got through. Just going forward in life, to be proactive on what kind of insurance you're going to get from the start is something to think about. But again, these things come up, and you can't plan for it. As my grandma Ethel would say, man plans and God laughs. So.
Right. Well, and I've had folks say, do you help folks pick plans based on their networks? And so I said, so first of all, that's beyond the scope of what we're taking on, but it can be really challenging, right? Because if you're looking at the network directory to make a decision about what plan you're going to go with, you're assuming that directory is up to date and robust, and you'll be able to take advantage of the long list of providers that's there. And it could turn out to be, it's a great list, but you can't get an appointment. So
yeah,
there's
so
sadly every reason to, as you said, be proactive in trying to anticipate what kind of specific needs you might have.
Okay. One last question here. This is a little more specific. So if it's not answerable, you can think about it, maybe get back to us. Do you have any advice for a 20-year-old with autism who's been denied ABA services because of their age?
So I don't. So I know that autism coverage is challenging. So that's not going to be terribly new news to whoever asked the question. There are certainly experts in autism coverage at Autism Speaks, and I certainly would encourage you to consult them. We have, I'll say, on our list of additional resources to develop over time, plans to include information to help people who are struggling with autism coverage, and we're just not there yet. But I have had the opportunity to interact with some folks at Autism Speaks, and what I believe is they have some good capabilities in terms of how to navigate care coverage, and certainly far better than we can.
Thank you, Joe. And this was a two-parter. Do you happen to have the names of any insurance advocates? And for me, what is an insurance advocate?
Right. So what I would encourage, so we don't recommend specific insurance advocates. What I would suggest is Googling appeals experts or denials experts. There are, I'll say, a relatively limited number of folks who are involved in this kind of work, and I think that's likely to lead you to someone who's helpful. I will say that the experts who I have encountered generally focus on appeals, and they don't so much focus on steps that you can take before an appeal. So that's just something to be aware of as you're looking to get potential input for overcoming an obstacle.
Thank you. We got one more that popped in, and it says, any ideas what will happen with psychology under ACA? I'm not sure what ACA is.
So it's probably the Affordable Care Act.
Yes.
So, in terms of what will happen, so I'll say only speculation about what could happen that's different from the current laws and regulations under the Affordable Care Act. The obligations that are relevant today are significantly defined in the 2008 law called the Mental Health Parity and Addiction Equity Act. And that law specifies that mental health has to be treated the same as physical health. I'd say it's a law that has the right ambition and sets the right expectation. At the same time, it's a challenging law to enforce, because the idea of saying, well, it has to be comparable to something on the physical health side let's say it's not always obvious comparable to what. And so it's one that I'll say regulators have struggled with since the law was first enacted back in 2008. And so I would say that's really what we try to do, is instead of waiting for the regulators or the lawyers to catch up, these are resources that you can use today to help yourself.
Thank you. And one more popped in. How do we handle HMO plans?
So HMO plans and I'll say Medicaid and certain other plans sometimes can be different. When it comes to medical necessity letters, the same principles apply. That's what experts have explained to me. HMOs can be more challenging when it comes to going out of network. So the obligation to go for a network to make an expert clinician available to you might be just a little bit more challenging with an HMO than it is with private insurance, and it's the same with Medicaid. So I think I would say medical necessity letters are a great resource to use. Reaching out to constituent services, a great step to use. Formal complaints for quality of care failure, I think that's another step to use. Appeals could be different, and that might vary by individual plan in a way that's really beyond the scope of what we've been able to tackle so far.
Thank you so much, Joe, for being here with us tonight, and your passion and your work to figure this out for so many people. In the chat, I put a very short survey. It will take you less than a minute to fill out. Please take a moment and fill it out so we can report back to our funders and make sure we're hitting the mark and providing meaningful content for you at No Shame on You. It is May Mental Health Awareness Month. We have a couple of really interesting programs coming up. Check them out in our calendar of events. I also put that in the chat on May. I'm going to get the date because I'm afraid I will not remember it. One moment. On May 13th is our next Feed Your Mind. It's our monthly Lunch and Learn virtual online program that will happen at 12 p.m. Central Time. We are partnering with the amazing Trevor Project on ally training through a mental health lens. So join us for that. And for people who are local to the Chicago area, we have a wonderful program, a documentary screening and panel discussion for an incredible documentary called Our Turn to Talk. And it's hosted by our Teen Leadership Board. It's taking place at 7 p.m. May 18th at the Wilmette Theater. Teens are invited, and anybody who serves them, loves them, and supports them are welcome to come. We have a great panel lined up. Thank you guys for joining us. You will receive a recording of this presentation probably early next week, so you can refer to it. It will be on our YouTube channel. Please share with anyone who might be interested in learning about these resources. And we want to get this in the hands of as many people as possible. Thanks everyone for joining us. Have a good night. Thank you, Joe.